Started. Hi everyone, welcome to the first HAS online seminar of 2026. We have our speaker with us, and I will do introduction and then he will start his talk. Please feel free to drop your question to chat or Q&A box, and he will go through during this talk and after the presentation as well. And today we have Dr. Qiushi Chen with us. He's an associate professor in the Department of Industrial and Manufacturing Engineering at the Pennsylvania State University. He earned his PhD from Georgia Tech, Goya Law Jackets, and then his postdoctoral training at Massachusetts General Hospital and Harvard Medical School. His research has focused on utilization of innovative mathematical modeling, optimization, data analytic tools integrated with real-world healthcare data sets to better inform clinical decisions, policymaking in broad healthcare settings. He has been collaborating closely with researchers from medicine, health policy, health economics, social sciences, and multidisciplinary research projects on modeling for opioid use disorders. His work has been supported by NIH and NSF. He served as a council member of the Informs HAS Society and currently serves as an associate editor of Healthcare Management Science. Welcome, Qiushi. Stage is yours.
All right, thank you, Malik, for the warm introduction. Good morning, good afternoon, everyone. Yeah, it's really my great pleasure to be here today. And I still remember, I served, as Malik mentioned, I served a council member a couple of years ago. I still miss those experience and memories. And yeah, I think it's a great way to serve this HAS community. And it's always great to be a part of this research community as well. All right, so today I'm going to talk a little bit about some of my work in the area of the substance misuse. Right, just like many other opioid substance research talks, will start with this graph, right? And I think most of us in this room probably already familiar with this background story about opioid crisis, right? It goes through multiple waves, starting initially fueled by the prescription opioid overdose, and then followed by heroin, and then synthetic opioid like fentanyl, and then now after 2017-18, it's starting mixing more stimulants, right? So I won't reiterate the stories in details, but I just want to show this graph, this number of drug overdose deaths in the U.S., just to put ourselves in this timeline, and particularly myself. I started working in this area when I was a postdoc at MGH, so that's around 2017. I think after, just like how dynamic this public health problem has evolved over time, I think my work in this area has also changed different type of works over the years. So what I'm saying is that at 2017, I would probably not imagine I'm doing kind of work I'm doing today. So but it's a very exciting and interesting process. You identify new emerging interesting problems in the space. So I think as industry engineer and operations research training background, so we have a lot of decision analytical models and data analytical models that we can leverage to help address this public health issues in general. Right, so today's plan, so I'm gonna briefly start with some of my early experience, the modeling experience on the opioid when I started in 2017, and then that leads to a interesting prevalence estimation problem that I have been working on, and then in the past few years, I worked with the colleagues at Penn State, so we start to look at the allocation of the opioid settlement funds. So there's a lot of interesting work we have done there. Including the actual technical assistance work with the state government, and that also leads to some more academic research type of questions we want to explore. If we do have time at the end, then maybe I can also talk about some work we've done on, this is more on the traditional, more conventional operations management, capacity management type of work, but that still in this general context of substance use treatment and services. Yeah, so that's pretty much the plan today, right? So I'll start with our initial work. So our first opioid modeling work really started with some random conversation in the hallway when I was a postdoc there. So well, at that time I was working on hepatitis C modeling, but I'm pretty familiar with this compartment model, simulation model, and then the colleagues there would just say, okay, can we do something about the opioid? The colleagues have seen some news and stories about this opioid and substance and drug overdoses. So I still remember I Google searched this because at that time I didn't even know what the opioid means. It's a new English word to me. So I searched. So there are news from time to time, from month to month, but definitely not like a national news on daily basis around the time of 2017. But then we do see in just like general news outlets, but also in research literature, there are more and more policy talks about this important public health crisis. So at that time, I think what the most focus is about on the prevention side, and pretty much focus on the prescription drug monitoring program. So basically, it will try to reduce the overprescription of the opioid drugs, right? So then we motivated by that idea, we started with this very simple compartment model at the national level. Everything is very aggregated, and we just want to understand one thing, that if we change the incidence of the prescription opioid misuse, how would that affect the trajectory of the overdose death pathways, right? So that's something we want to analyze. So we find some data to calibrate our model, parameterize our model, and then did the projection at that time. So actually, the result is not very promising and not very comforting. And we find that even if we assume there will be zero incidence in the next like 10, 20 years, then projected overdose death will not really, we cannot really bend the curve very much. If you look at this, the orange line in the bottom, that's the hypothetical case with a zero incidence. And cumulatively over 10 years horizon, and the total reduction of overdose death will be just less than 20%. And so that's basically says that if we only control or mitigate the incidence part, only focus on prevention, that's probably not enough. And then that leads to the discussion of, okay, we need to advocate for a multi-pronged approach, prevention, treatment, and reduction, those can all these things together to mitigate this crisis. So that's pretty much how my line of work in this area started. So over the years, I still work with the MGH group, and so we extended our initial model to incorporate more interventions like the medication harm reduction. And we go from a compartment model to microsimulation model that is at individual level. And then we also look at a more refined geographic levels from national to state level. And most recent work, we try to build models for local communities at the county level. So over all these years of experience, then I start to see there's the model calibration validation is always challenging, and it does require a good, reliable data, particularly for the prevalence, because this is important. The prevalence describes the disease burden. That's the direct measure of the disease burden in the community, right? So, but then when we work on the county level modeling, finding the prevalence estimates is always a challenge for us, and we end up finding some workaround approach to adjust some parameters in the literature and make it work. But this leads to a more general question for me, right? So how do we get the good prevalence data? So to that particular question, then the typical go-to sources is going to be a national survey. So we do have this national survey on the drug use and health, so NESTA. So NESTA, it does provide the public use files for all the subjects, but they stripped out all the geographical variables for privacy protection. So you use this data file, you will not be able to get a county level estimates. So they do also have this public reports and the tables on their website. They do publish the national estimates, state estimates, sub-state estimates. Sub-state means most of the time it's a group of counties, but never down to the county level, right? So if we want to build a model for certain counties, so this data source will not be very useful to inform that specifically. So other than this survey, so we also look into the literature of the epidemiology statistics, and this table is not a exhaustive list of the existing prevalence estimate works, but it does provide pretty much a landscape, like how what does literature look like, right? So briefly, so some studies they have the luxury of access to the individually linked data sets within the state, so they can conduct this capture analysis, which I think provides the most reliable estimates of the prevalence. But some other studies focused on using the statistical models to integrate aggregated estimates. Aggregated, I mean, the data set is not at the individual level, but more at the county level. They have a number of ED visits, number of overdose deaths, those kind of data. So that can also make it work, make the statistical model work. But all this are pretty much focused on the specific states, or either specific states or at the national level, right? So suppose if I want to build a calibration, want to build a model for some state outside of this list, I will be run out of the resources, right? So I will not be able to have a good prevalence estimate supported by any evidence. Yeah, so because of this limitation of the state-specific studies in the literature and the lack of geographic granularity at the national level, then that leads to a question: Can we do this? Can we provide a estimated prevalence in a good way, in a smart way, so that we can have a comprehensive estimate for the whole country, for every county? So that leads to our first work on the Bayesian model for the prevalence estimates. Okay, so as I mentioned earlier, so this is motivated from our challenges while we're doing the model calibration, and that really leads to just a very general research question for the small area estimation. How can we estimate a prevalence of opioid misuse at a county level across the country? And here, I also wanted to be limited to public available data sources. Yeah, because it will just improve the generalizability, right? So of the results. If you want to build a model for certain country, certain state, and public available data sources usually are more widely available, so that will increase the applicability of the results, right? So that's our goal, right? So we want to incorporate the best evidence at multiple levels. So the best available evidence refers to existing prevalent estimates. Some are from state-specific studies, some are from national surveys, right? And also want to focus on the public available data sources. Yeah, so that's our starting point, right? So then how are we going to approach this? So this is our general design of our strategy. So conceptually, we just look at the entire US with the 50 states. Some states we can have this county level estimates. So they are from published capture studies. And very few of them. We'll talk about only 2 studies that we're going to use in our later. The remaining 48 states, we don't have county level estimates. Okay, so how can we piece this puzzle together? Okay, so conceptually, I would believe that this prevalence are associated with the county level social demographic variables, right? So these are intrinsically associated. I try to avoid the causal claims. I would just say they are associated, they are correlated with the county level information. If we can learn, okay, let me pull this. If we can learn about their association from between the county level estimates and the county levels variables from limited states, maybe we can leverage that knowledge and apply them to other states. So that it can help us infer what's going to happen here, right? So that's kind of idea. But then we have to also realize the opioid epidemic or substance overdose crisis not impacting every state in the same way, right? So that means we have to somehow capture the state heterogeneity because not all counties are heterogeneous across the states, right? So different states have very different situations. Yeah, so we have to somehow capture this. So then we can leverage the state level estimates from NSDOH. So that is widely available across all the states that can help us capture the state heterogeneity. We can also use the overdose death data. So that is also available widely across all the states across the country. So that can help us capture the state heterogeneity, right? So that's the general idea, right? So, but still, I want to point out two caveats. One is that the numbers or the results from NASDA has been commonly widely criticized in the literature about the underestimation, because number one, it's self-reported outcomes. Number two, they only include the people who are not institutionalized. So that means they don't include homeless population or people in the incarcerated settings. But these populations are oftentimes disproportionately affected by the substance use, right? So that's the caveat we should keep in mind. So for the overdose death data from public sources, which is the CDC Wonder database, we can do the query. Everybody can do the query on the web page. But because it's public available data, so they will suppress the values if it is below 10, right? So then we don't know the very low values. We only know the exact values above 10, but so that leads to some data quality issues. That means we have the data suppression we need to take into account when we build models, right? But anyhow, so this is our general approach, with our strategy. That's how we want to put things together and estimate the prevalence at the county level for the states that does not have a study have been done before. Okay, so how do we operationalize this? So we build the Bayesian hierarchical model. So this is a statistical model. Then here is how we're going to define it. Okay, so first I'll define the prevalence. Okay, so the prevalence represents the probability of an individual in the general population in that county has opioid misuse. Okay, so that's a probability P. And we model this as a logit link function, as a linear function with respect to the county level social demographic factors. I call that prevalence determinants. Okay. And then second, I will model the mortality rate. So this mortality rate represents the probability among the individuals with opioid misuse. Okay, it's not among the general population. It's among those who have opioid misuse. So this is a mortality rate. Is also modeled as a linear function through this logit function. Okay, so graphically, I'll just illustrate it through this graph, right? And then I will model the overdose death counts, right? So that represents, that's the D for I. So that's the data we can observe. So we model that as a Poisson random variable with the mean of NI. NI is the size of the general population, right? General population multiplied by the prevalence rate and then multiplied by the mortality rate. Right? That gives us the total expected number of overdose deaths in that county. Right? So then put all things together, we already put these pieces in this diagram. Right? So that's how we started here. Then the question is, how do we link these quantities to existing evidence, existing data? So here we go. So we first link with the county level estimates. Okay, so that's from the capture-recapture studies that are published in only very limited states. Okay, so one thing we have to realize is that for those papers, they publish the estimates, the prevalence, not for opioid misuse, they are for opioid use disorder. So these two terms have a different meaning. So opioid misuse is much broader concept than opioid use disorder. Opioid disorder is a specific clinical diagnosis that meets certain diagnosis criteria. So usually it's used in the more restricted settings. But what we want to focus on is the opioid misuse, because we see this as the population at a risk of having overdose death, right? So not only limited to the opioid use disorder population, right? So this is how we model this. So the P hat, so any notation with a hat represents the existing estimates, okay? So P hat, we model that as a log normal distribution, and with some parameters. So this just a bunch of parameterization to make the mean of the log normal to be this and the standard deviation to be this. Okay, so to be more specific, the PI times RSI. So the PI is what we assumed earlier, modeled earlier for opioid misuse prevalence for county I. So this R represents the ratio, okay, connecting the idea between misuse and the opioid. Right, so this will be a ratio less than 1. Okay, but we do not know this ratio specifically. So, but we can infer this ratio by additional values that's available in the NSDOH survey. But that one is only available at the state level. So now we define this state-specific ratio informed by this. Okay, so the NSDOH does have measure on both definitions, so that gives us a indirect information to infer this ratio. Okay, so then we put this together as well. So now we have a model that incorporating county-level estimates of OUD prevalence from capture studies, and also using the NASDA state-level estimates to help us infer this ratio. So there's one more thing we can still add. It's the state-level estimate of opioid misuse from NASDA itself, right? So then we'll just define this p-hat at the state level. Similarly, we'll just model that as a log normal random variable and with some parameterization. So here, if you remember, the one caveat we highlighted earlier is that underestimation of the NASDA estimates. So to capture that, we'll particularly define a variable, this ratio, to capture the underestimation of the NASDA. So that will be built into our model, and our model will also learn what will be the underestimation ratio here, right? So that pretty much builds up the entire model, a statistical model that we want to fit. Okay, so as we mentioned earlier, the state level heterogeneity is going to be very important, right? Because not all states are impacted in the same way. And right now, our current model, this is our core model. It does not really differentiate the state, right? So all the counties are just instances of the I, and we are not really capturing the state level differences. So how do we incorporate that? So then we're going to start to introduce the random variables. So we want to introduce state level random variables, random effects on these models, right? So then we can start with the adding intercept to both prevalence model and the mortality model. So we can have that as a random effect. We can even further estimate. So this random effect of intercept just give you the different baseline. It's going to just to adjust for the baseline at the different states. But it does not really explain, okay, how the county level social demographic factors are associated with the prevalence differently, right? So to address that, we need a slope. So technically, we can also add a random effect to the slope. But just keep in mind that this will be a lot of new parameters we need to fit, okay? So the general principle of building a model, in my opinion, is always starting with a simple one, right? So, and we keep adding the complexity unless necessary, okay? So that's my strategy. So after 2 slides, I'll come back to here to show you how we're gonna go through this process guided by the data. So it's gonna be a data-driven decision, how much random effects we're gonna need for this model. Okay, but here we just show, okay, this is the possible additional complexity we can build into the model to capture the state level heterogeneity. Okay, so that's the full model structure. And now I'll just be more specific about what the data sources linked to this data, right? So all the circles with the shades with different colors, that's where we can tie to the data. So for this too, that comes from the OUD prevalence estimates from 2 particular studies, one for Massachusetts and one for Kentucky. So then the next purple numbers will come from the NASDA estimates. So they are only at a state level. And then we have the population size from census data, and we have the number of overdose deaths that we can query from the CDC Wonder database. And all the covariates, the mortality determinants, prevalence determinants, I believe we included the prescription rates that is available in the CDC website, and there's some other unemployment rate, income level, those are available from county health rankings. So they are all essentially coming from the census data as well. Okay, so this is how we link the model to the data specifically. And our baseline reference year is 2015. So we try to align the data set to 2015 as much as possible, because that's pretty much where the Massachusetts study is positioned at. But when you work with the data, sometimes it's not that easy to align up everything. So we'll if we cannot find the exact 2015 data, we'll try to choose the best available data source in the year that closes to 2015. Okay, so that's the data we used. Okay, so this slide is pretty standard. It just says that, okay, this is the parameters we need to infer. We can put it together, the total likelihood. Because it's a Bayesian model, we have to specify the prior. We use the very weakly informative prior. And one thing very interesting I learned during this research is that some prior called horseshoe prior, that is just a parameter shrinkage method. So it's basically a analogy of the lasso for logistic regression. So it basically can push the parameter coefficients the model thinks is not important close to zero. So that only leaves some important features and to maintain the sparsity of the estimated parameters. Okay, and we implement this using the stand to run the Monte Carlo. It's a special type of MCMC to estimate for the computation of this Bayesian model. Okay, so let's come back to the issue I left off 2 slides ago about this state level heterogeneity, how much random effect we need, right? So we started with this model because now we have a fully defined plan for this model, for run this model. So now we started with a model without any random effects, okay? So everything is based on what we introduced earlier. So then we look at residues, okay, of the estimated overdose death versus observed overdose death for every county. And then we calculated the residues within the county and find out what's the average residue, what's the confidence interval of the residues across the counties by state. So this is trying to capture, okay, how well our current model without any random effect has captured the heterogeneity in the overdose death data, right? So as expected, this model without any state level heterogeneity should not capture very well of the variations in the data. So we will see a lot of these red states, they are having the residues very significantly different from zero, right? So that means, oh, this model is not sufficient, has not fully captured what's happening in the data. So then let's start with adding this random effect one by one. So let's start with adding the random intercept for the mortality model. Once we add that, this has been substantially improved, leaving only 2 states. Still, I would say almost like a borderline cases, not really with some residues statistically significantly different from zero. Okay, so then we say, okay, we can still add a random interceptor to the prevalence model. Let's see how that's gonna improve. Okay, and then after adding that, we still have one more, okay, for the Kentucky. And so then we thought about, should we keep adding the random slopes in those models? Then we feel, okay, that may just add in too much model complexity. And now for most of the states, we are already pretty good, right? So then we just stop here and then living with this non-perfect residues. But I think overall, the model should behave, should adequately capture the state level heterogeneity so far for majority of the states. Okay, so that's where we stop at of adding the random effects to the model, and then we proceed with this model specification with the random intercept for model mortality model and also prevalence model. Okay, so let's see what the results look like. Okay, so that's pretty much our model specification. For the cross validation, so we want to validate our model has a decent performance. So we first focus on those 2 states, okay, with the county level prevalence estimates. So there are about 134 counties, and we just run tenfold cross validation among these 2 states. And then we find the MAPE, the mean absolute percentage error, around 45%. So for small area estimation problems, our collaborators from statistical side also told us that for small area estimation problems, this kind of error is kind of pretty moderate, okay, pretty good. So 30 to 40% of MAPE is usually reasonable. And also we show the strong rank correlation with the model estimated values and observed values. And more importantly, if we look at the coverage, by our prediction intervals. So the previously it's just point estimate and a point estimate. Then if we think about the interval estimates, then we look at how much our predicted intervals cover the original point estimates. Actually, that's a pretty high percentage. So this gives us the confidence that our model is capturing the existing data reasonably well. And also, I want to highlight that the Massachusetts has only about a little bit over 10 counties, and the majority of this is driven by Kentucky. And if we look at the Massachusetts, actually we'll do a pretty decent job. So the MAPE for Massachusetts counties is only about 13%. So that is really a good signal showing, okay, our model captures this the patterns in the data reasonably well. Okay, so that's the cross-validation for the overdose OUD prevalence. So we can also do another stratified tenfold cross-validation in county and the states for all the states. So then, if we focus on the overdose death, the error is about 37% among those counties with unsuppressed values, and it has a pretty decent interval coverage as well. For the suppressed values, because we don't know what exact number of overdoses are they, so we calculate the percentage that our predicted values actually is in the suppression range. So actually, we find that, okay, most 90% of the counties with the suppressed values, our model could correctly identify them as a suppressed counties. So that's the validation of our model we have done. Okay, so then one more step before we move to the national map, right? So we still want to make sure our model is making sense. Okay, so although this validation results looks reasonable, okay, so then we look at our coefficients, try to see if that explains things in a reasonable way. So first we look at this random effect. Okay, so this variance for that random effect intercept. So first of all, this is sanity check. So that shows that, okay, our model does correctly capture this random effects for both intercepts. Okay, and then we also look at this underestimation ratio for the NSDUH. So this gives us about 0.21. That means that is equivalent to about like a multiplier of 5. So that means the actual prevalence is about 5 times higher than what NSDUH estimate says. So this number actually, this multiplier of 5 is pretty much aligned well with the existing literature. I have seen the multipliers ranging from 3 to 8. So that's right in this reasonable range. Okay, so in addition, we look at the coefficient. Okay, so that are those covariates making sense? Okay, so we find out opioid dispensing is positively associated with the prevalence rate, and we're talking about 2015 years. I think around that time, that's sounds reasonable. And also talk about a coefficient of smoking. So that is positively associated with the mortality rate. That sounds also reasonable. And one thing we do see a little bit of conflicting is the unemployment rate. So it shows a positive for prevalence, but a negative for mortality. So I did look into the literature for the unemployment rate. There are mixed evidence about this, and there's no really like strong dominating conclusion say that it's either positive or negative associated with this. So I think with overall together, I think our model is relatively reasonable. So we take this as a sanity check, and then we move to our final results. So that is the map that we wanted to build from the first place, right? So we provide county level prevalence estimates across the country. So this map is the posterior mean of the estimates of the prevalence, and the redder area represents higher prevalence, and the bluish area represents the lower. So we can see there is a clear cluster around the Appalachian area, so that is known to be have a higher prevalence of the opioid misuse, and also the northeastern area, New England area, that also show the higher prevalence. The West Coast also showed higher prevalence, but in the meantime, I also generated a map not only for the point estimate, but also for the uncertainty, right? So the uncertainty indicate as presented by the standard deviation. So for the West Coast, although they have a higher prevalence, but they also have a higher uncertainty in the estimates. So the lowest uncertainty comes from Massachusetts and Kentucky. This is only because we use the county level estimates as a part of the data for our model. So that they should have more confidence on the estimates generated from the model, right? So when we see these two blue clusters within these two states, we feel, okay, this is reasonable. This is exactly what I expected. And also just come back to this posterior mean at the county level. Then overall, the median of the county level prevalence estimate is about 5%, and with the interquartile range from 4.2 to 5.9%. All right, so that's pretty much our results of the prevalence estimate project. And just to summarize, and we provide a unified framework to integrate a diverse set of public available data sources. And we tailored our model to capture the underestimation in the national survey and also accommodate this data suppression in the public data sets. We are, to our best knowledge, we are the first to joint estimate this county level estimate prevalence for the entire country. So I think that's pretty cool. During our paper revision, actually, we find out there's another archive paper as well. They are trying to do the national estimates, but they are taking a different approach. And then I hope we build a generalizable framework, and we can imagine if there are new states that can conduct the capture analysis, provide a state-specific estimate, so we can easily incorporate those emerging evidence into our kind of framework, and then that will just increase the to help further enhance the strength of the overall estimates across the country. So in the current model, we are only take a cross-sectional point of view. It's only for one particular year, and we are not we're capturing the county correlations through the covariates, but we are not explicitly capture the spatial information, right? So the our current work extension from here is to capture the spatial aspects and also extend it to the temporal, to capture the temporal trends in this estimation models. Yeah, so I think that's pretty much for the first work that I want to share about the prevalence estimates. Maybe I'll just pause for a few seconds, see if anyone has any burning questions I can help to clarify. Okay, right. If not, let's move on to the next one. So it's about the opioid settlement fund. Okay, so this is going to be very interesting, experience and also a story about working with the real stakeholders and how that leads to a research question. Okay, so settlement funds. Okay, so you probably have heard about it a couple of years ago. There was lots of lawsuits filed by the government against the big pharmaceutical companies. So since 2014, there are more than 3,000 lawsuits has been filed. So what they say is that, okay, so these big pharmaceutical companies did not do their diligence and and fueled the opioid crisis in the first place, and leads a lot of loss of lives and also economic burden to the states. And then the states ask for compensation so that they can use this money to help abate the damages they have done and also to mitigate this ongoing crisis. So that's essentially the argument, right? And because there are so many lawsuits out there, and then in this particular day, there has been a settlement by four big pharmaceutical companies reached a settlement with the 46 states in the United States as a aggregated settlement. So this adds up to $26 billion of the settlements so the state can decide either they want to receive the settlement money, or they if they receive the settlement money, they will need to resolve the existing and the future claims so against this pharmaceutical companies. So basically, they will just withdraw their lawsuits, right? So that's the settlement. And for Pennsylvania, they get about a little bit more than $1 billion. And so then the question is, the question for the state government is, they need to make sure all the counties sign on this joint agreement, and it basically means that they will take the money and then then resolve all the lawsuits so that the state government can actually receive the money. Okay, so then the question for the state government is that they need to present the county with a plan how much allocation, how much settlement each county can receive, so that counties will think about it and decide whether to sign on this agreement. Right. So that's the questions presented to the state government. So essentially, this is $1 billion question. How do we allocate the money across the counties within the state? Right. So I was very fortunate to be a part of the team with the senior colleagues from health policy departments at Penn State. We're working with the state Office of Attorney General directly to determine, okay, to find a way to allocate this settlement money. And our goal is to have evidence-based, transparent, and also a fair allocation to the counties. And we don't want a very sophisticated optimization model, and a simple formula would do the work. Okay, so what we did is within this 2-3 months, the very intense period of the work. If you remember, this settlement was made in July, and then we started working on this in August, right? And within 2 or 3 months, we have collecting empirical measures about opioid crisis in Pennsylvania at the county level from a lot of data sources. I think we went through more than 40, 50 different measures available. And we assess their relevance, representativeness to see overall quality, if it is good or not. And then we also had a lot of discussion with the community stakeholders and collect their feedback and input on what they think is relevant and important measures to consider. So what we end up settling with is a simple formula with a 4 metrics, and every county will find out, okay, how much, for example, how much county A contributes in terms of percentage of the total overdose deaths in the states, right? How much this county contributes in terms of percentage of the hospitalization among all the states. And then we just do the weighted sum of this percentages, and then it will get a percentage, final percentage of the settlement money to be allocated. And then some, as you can imagine, Pennsylvania has 67 counties. Some are very rural, very small, and they will end up having a very small percentage, and the total will be even less than $1 million, just to have a gesture to have a fair allocation. So we have a top-up amount, make them to $1 million, and then just scale the allocation among large counties proportionally to maintain the total sum. Okay, so that's essentially the solution we came up with through this actual process. Okay, so then this Office of Attorney General put this in the formal legal document, send it back to the counties, and waiting for the counties to sign on this agreement. So by December, so this was sent out in December, early December, and by later December, 75 counties signed on, and a few days later, 10 more. And by the determined deadline, all counties have successfully signed on this agreement, so that the state will get a maximum number of the settlements. Okay, so that is the end of this story, but it's just the start of the research. So the way I see this is that this formula, okay, only gives us a working solution that is reasonably keeping all the entities involved happy within a short amount of time. Okay, but by no means it will be the only way to do it or the best way to do it. All right, so then putting on my academician's hat, we always wanted to push the limit a little bit more and see, okay, can we really do better, or what are the potential issues in the existing working solutions? Right. So, oh, and by the way, if you want to know more about the conceptual framework and the process, we written this up in the paper that describes all the details here. Feel free to check that out. Okay, so then back to this $1 billion question to me is, okay, is there a good way to allocate the settlement dollars in a more systematic way? And our initial goal is to have evidence-based, transparent, and also fair. But if we really think about a fair, how do we really define the fair? So the previous formula would kind of implicitly make it fair through communications with the local stakeholders to get their input and keep everything transparent, to keep to make our final solution to be fair, indirectly and implicitly, but can we have a more explicit way to address this fairness issue? Okay, so that's my question. That's a question that's been haunting me. Then I think about, okay, how can we use a model to systematically solve this question, answer this question? Okay, so then we started with a very generic framework. Okay, if you take this question and make it a very abstract, it's actually a simple question. So we have a bunch of metrics. So that's empirical metrics. That's the data. We can observe multiple metrics. Previously we used 4, but it doesn't have to be 4. And then for every county. Okay, and every metric, each county, some metrics could be higher, some metrics could be lower. Okay, and then the decision is really what's the percentage of the total settlement I want to allocate to each county. Okay, so then in a very abstract view, we just want to make sure the total allocation is 100%, and every allocation to each county should be justifiable based on the range of the empirical metrics. Okay, for example, if I only have 5% of the overdose death of the states in my county, I don't think I should argue for 20% of allocation, right? So that's not fair. It does not align with the empirical evidence, right? So that's why I want to make it reasonable so that the allocation is bounded between these empirical ranges. Okay, so now the question remains to be, okay, I want to minimize the inequality or inequity or maximize the fairness, right? So that's kind of my objective function. But still, this is kind of like a very abstract idea. What is the fairness? How can we define the fairness? So then we look into the literature. There are a lot of algorithmic fairness discussions talking about and about a parity, and also there's fairness measures in the social awareness functions, that kind of framework. But for us, it's not really that applicable directly. So then I go back to some health economic literature and I try to see, okay, how can we conceptualize this in a reasonable way? Okay, so in the health economic literature, there are commonly 3 principles to define or introduce the equity: either allocation to ensure equality of access, but remind ourselves that this settlement funds are not for general population. They are intended for supporting the activities like prevention, treatment, harm reductions to abate, to support the people with the substance use conditions, right? So then it's not to improve the access of general population, like improve the primary care or vaccination through that. So we are not really looking at equality of general access, right? So in terms of the third one, equal distribution of health outcomes. So practically speaking, from the settlement allocation, allocating the money to you see the improved health outcomes in this targeted population, there's a long way to go, right? So the effectiveness remains to be even evaluated. So there's no way for us to immediately assess what's the outcome that can be translated from invested allocation funds. Right, so we feel that number 3 is also not very applicable here. So it seems like it only leaves us to the idea of, okay, allocating based on the need. And also in the literature, the opioid past historical opioid-related outcomes can be served as reasonable measures for the need for a region. Right, so then we finally settle on this idea. Okay, we're going to use the outcomes. Previous outcomes, empirical measures to represent the need of the counties. And then we don't want to aggregate them into a single scalar. I still want to maintain these multi-dimensional measures, but we just want to use that in a smarter way. Okay, so our model. So how are we going to define this? So number 1 is that I want to define this fairness as a measure by calculating its deviation. So from central planner perspective, I want to allocate my resources in a way that it aligns with the supporting empirical metrics as well, right? So this gives us the idea, kind of like when you run the regression model, you want to draw a line that aligns with the data points well to minimize its deviation. So that's where we get this idea from. So we minimize the relative deviation because the absolute value of this empirical metrics can differ by order of magnitude. Okay, so that's the first idea. The second idea is that it's motivated by some conversations during those stakeholder meetings. some counties would argue, okay, so I have 3 or 4 different metrics. So one metric is particularly high. Okay, maybe one metric constitutes like 5% of the state, other metrics is only about 1% of the state. Then I would argue that the highest metrics is going to be very important, right? And I deserve 5% of the allocation, right? So in that case, we can say, okay, some of the metrics could be more favorable metrics. And if I don't get the same amount as the favorable metrics, then I kind of have some kind of regret, right? And reality is that not every county can actually get the percentage based on their favorable metrics, because they will add up to be above 100%, right? So in other words, we cannot make everybody happy, but we want to make sure the least happy person will not be too unhappy so that he will decide not to join the agreement. So it's going to break the deal. Okay, so then our goal becomes, we want to make the least happy person as happy as possible, right? So that's why we come up with this idea. We will minimize the maximum regret among the counties, right? So that's kind of the mini-max regret definition. Okay, so what it follows the rest is pretty straightforward. It's just a simple optimization problem. I think most of our work goes to how we conceptualize these fairness ideas, right? And then just for comparison purposes, we also added this alpha fairness just for comparison. So alpha fairness, we need to define the utility. So that's we just use the proportional scores. So that means if you are allocated to your least favorable metric, you get a utility 0. If you allocate it to the most favorable metric, you get a utility 1. And then we can plug in these utilities into these functions. So that's alpha fairness. And in addition to this, we also remember that the formula that we give to the states is a simple formula, but the simplicity actually has some advances because it's easy to communicate with the local stakeholders, policymakers. So we said, okay, instead of this kind of solving from black boxes, can we make it interpretable by enforcing my allocation to be presented as a linear function of the empirical metrics? So then we can easily add this interpretable constraints to make sure that allocated, to make sure that in the end we'll still have a formula that we can present. And this weights for each of the metric, we also want to put them in a reasonable range so that it will not be one metric dominate the rest. Okay, so that's essentially the add-on part. So this part could be added to each of this formulation individually. So that's pretty much our formulation. So in the next few slides, I'll quickly show you the results, and then I think will be almost the time. Okay, so this is the results. So we have 67 counties in Pennsylvania. I can only show. I just showed several representative ones. So the first 3 are the 3 largest counties by population, and then the next 3 are the 3 smallest in the population. So let's first look at the mean deviation allocation, right? So it appears that the mean deviation allocation is going to favor large counties and have a less favor on the least counties, right? So I think the main reason is that this empirical metrics in the denominator. Okay, so in the denominator, the smaller counties will be more sensitive to this, right? And then the allocation is going to be very careful not to deviate from the small values too much, because once divided by a very small value, that's going to increase this penalty too much, right? So that turns out our model, the mean deviation model, tends to favor the large counties. So on the contrary, the mini-max regret allocation tend to favor the smaller counties, right? And the reason is that it's also because of the denominator. Okay, so for the large counties, if you move a little bit on the xi, and the large county is not very sensitive to this, right? But the small counties will be more sensitive in terms of this regret, right? And then if we look at the range of this alpha fairness, when alpha is large, it's almost close to the worst case optimization problem. So that should be similar to this minimax regret. Okay, but once we have a smaller alpha values that tend to leaning towards the efficiency rather than equity, right? So in this case, the reason why this alpha fairness with the smaller alpha is going to favor more on the smaller counties over the large counties is simply because if you are able to move a little bit from the large counties to small counties, it does not affect the utility of the large county too much, but it means a lot to small counties, right? So, and since if we want to maximize the utilities, then that will give us a lot of advantages to the utility of smaller counties, and that will further improve the objective function. Okay, so that's kind of the interpretation behind this kind of allocation result. Okay, so so this is the frontier that we show because we introduced the two fairness measures, right? And then it will be very interesting to see. Okay, these two measures, essentially we have a multi-objectives, right? What's the trade-off between them, right? So this is the frontier we find out. So there's no solution is to go beyond to the southern west area of this frontier, right? And we also observe that in this space of the fairness space, if we increase the alpha values for the alpha fairness, the results tend to converging or approaching this fairness frontier, right? As that's expected because as we have a higher alpha values, the alpha fairness tend to leaning more towards on the equity part rather than effectiveness part. And if we look at this a formula-based solution that we handed over to the state earlier, right? So it's still a little bit of distance from the best we can do in terms of the fairness, right? So that means the possible solutions on this frontier is going to be better than the formula-based approach we have earlier on both criteria. Okay, so maybe the one last slide I want to share is that so what if we added the interpretability constraints? So what's the price of interpretability, right? So then this blue line represents the new frontier after we have this interpretability constraints that enforce the allocation to be a linear combination of the empirical metrics. So we can see it move towards the top right direction. So that means that generally it will be less fair in terms of this regret and the deviation, right? And if we look closely, most of the changes will be increase in the maximum regret. So that means this maximum regret measure is a little bit more sensitive to this interpretability constraints. Okay, so so we did some analysis on the disparities in terms of fairness, but I think for the sake of interest of time, I'll skip this, and I'll leave it here to the summary about this fairness, fair allocation of the settlement funds here. So I like this work as I think it's not very sophisticated modeling, but it dives into the idea of, okay, how do we think of this fairness of the allocation of the fixed amount of the resources? And we provide a data-driven approach to facilitate this process instead of arbitrarily determine the weights of the empirical metrics. And I also would like to highlight that we only take a social central planner's viewpoint. Apparently, there is a lot of dynamics between local governments and the state governments. There's a lot of political dynamics happening there that's not captured in this model. So that could lead to potentially future works that to look at this problem from game theoretical framework. Okay, so with that, I'll okay, so I'll just finally thank all my collaborators, the former students, current students, for the hard work to make this all happen, and also acknowledge the funding support. Without all this efforts and the support, this work would not be possible. And I guess I'll stop here, and I'll welcome any questions.
Thank you so much, Qiushi. That was a great presentation. I really like the second projects, how it is converted to a very good implementation and problem solving, and it is just fascinating. I'm impressed. And for your first work, I have one question. I think while we are all dealing with this type of data, in real world, we are seeing similar type of problems out there. There's a survey data which is underreported most of the time, but on the other hand, we have some level of granularity, national data or county level data. But when we come across with adverse events like overdoses or suicides, whatever, it is very hard to match this data, come up with a good enough data in order to fit our compartmental model. So the question is, your framework looks very good and very good way. It is a very good problem solving way to come up with a data. Did you have a chance to apply this framework to another setting with another, for example, for another disease itself, let's say mental health and suicides, something like that, or just did you try it for the specifically on opioid use disorders?
Yeah, that's excellent question. I think that's a very generic problem settings, right? So I think, as you said, all kind of challenges we're facing when we build the opioid models. So yeah, that gives our idea of like estimating the prevalence. And yeah, we haven't tried other settings yet, but I think what you said, the suicide prevention, that's a very important topic recently, more importantly. And yeah, so I think that would definitely be the promising areas to look into. Yeah, I think they share, and really the opioid overdose death, if you work with the people more from health policy and the epidemiology side, they will actually look deeper at overdose deaths. Some are accidental, some are actually involved suicide as well. So this, I'm glad you mentioned the suicide prevention topics. I think that's also closely related to the substance use. Yeah, so I think that's excellent comment. Yeah, we haven't looked into that, but I think that will be a great idea to start looking into.
Okay, thank you so much for accepting our invitation. We're almost the time.
Sure.
Already passed. Sorry, already passed. So, and thank you so much for serving us online seminar series as well. And it was our honor to host you here.
All right. All right. Thank you. Thank you again for inviting me. And it's really my great pleasure to speak here.
Thank you,
so
everyone.
much.
All right. All right. Take care.
See you next one. Thank you.
See you.